The testing algorithm or diagnostic algorithm for patients with advanced non-small cell lung cancer has evolved over the past 12 to 24 months. Patients with advanced stage adenocarcinoma at a minimum should have EGFR, ALK, ROS, and BRAF. Those are the four genetic aberrations that have targeted therapies that we can deliver. But we've learned recently of emerging biomarkers or genetic aberrations that also may be predictive of targeted therapy. In-track fusions, now we have a drug, larotrectinib, that is approved. MET exon 14 skipping mutations, HER2 mutations. And so I think because of this, because we have approved biomarkers, but we also have these emerging biomarkers, we should be doing comprehensive genomic profiling on all of our patients with advanced adenocarcinoma of the lung. And so we get one fell swoop. We get it in one testing. We get all of the genes of interest that we're looking for, and we can then make treatment decisions based on that. I would say for patients with squamous cell, advanced stage squamous cell, we generally do not recommend molecular testing. But if a patient is a never smoker or light smoker with squamous cell, then we would do the same testing, a comprehensive genomic profiling on these patients in attempts to find a molecular aberration that we could act on with a targeted therapy. In addition to molecular testing for patients with both advanced adenocarcinoma and squamous cell, we of course need to be doing PD-L1 testing. PD-L1 should be done again on all patients, and it can help drive decision making for patients that don't have a genetic aberration. We know that patients that have a PD-L1 greater than 50%, these patients should be offered single agent pembrolizumab or can be offered the triplet therapy with carboplatin, pemetrexed, pembrolizumab if they're symptomatic. And that patients with less than 50% should probably not be offered single agent immunotherapy. These patients should be offered generally chemotherapy with immunotherapy, but not single agent immunotherapy. And just a reminder that the PD-L1 testing should be done in conjunction with molecular testing, and PD-L1 shouldn't be driving decision making until we know the molecular aberration. It's important that all patients with advanced stage non-small cell lung cancer, specifically adenocarcinoma patients, get tested up front for comprehensive genomic profiling. I think there's a lot of questions still unanswered whether testing should be done upon relapse. Patients who are on targeted therapies, who do have progression or develop progression, I think this is an opportunity to perform comprehensive genomic profiling to understand what the genetic underpinnings are for mechanisms of resistance. This can be done, of course, with a tissue biopsy or oftentimes with a liquid biopsy. So patients who are on a targeted therapy, who have a genotype that we're giving this targeted therapy to, I would say that molecular testing is important both at diagnoses and when they are progressing or have relapse. Patients without genetic aberrations who aren't on targeted therapy, I wouldn't consider testing them comprehensively upon relapse unless I didn't get all the information up front. If there was some limited tissue the first go around, they started on treatment with chemotherapy and immunotherapy, and when they progress, this may be an opportunity to rebiopsy the patient. But on a routine patient in clinical practice, if I have enough comprehensive genomic profiling, the results, I generally will not retest them if they're not on a targeted therapy. It's so important that comprehensive genomic profiling, our next-gen sequencing, is done on all of our patients. We've learned not just about EGFR and ALK and ROS and BRAF, but these emerging biomarkers that have really effective, minimally toxic, genotype-directed therapies that we can give to these patients. And it makes a huge difference in terms of how likely their tumor is to shrink, but also their quality of life. So I really highly encourage every effort be made for comprehensive genomic profiling, specifically for advanced adenocarcinoma patients, but also for our advanced squamous cell patients who are light or never smokers.